Good. So yeah, it's great to be with you, and I've been able to listen to most of the proceedings, and I appreciate the chance to put some opinions out there based on what I've heard. And I do feel like I'm getting old enough now to be able to say I have had a lot of experience in all the different sectors that are involved, and very excited that this is being taken on as a topic. Let's see, I transiently saw the slides there, but so I'll just keep talking while we're waiting on the slides. I wanted to make a few just sort of opening points, which, there we go. Let's go to the next slide. There we are. Okay. Yeah, so these are some pretty basic points, but I think this is something I've learned, and it pertains to every sector, including, I might add, academia, where I spent most of my career. You probably, if you want to see things improve in an area, you need to follow the money. But one thing I learned a lot about at FDA in my time in government, and now seeing it from the perspective of the tech industry, is that you can change the flow of money significantly if you fix the policies. This is called moving the cheese in popular vernacular, but it's a real opportunity that I hope we have, because regardless of who wins the election, there's always a policy window right after an election where things can happen that alter the incentives in a way that can improve the situation. And I believe, based on everything I've seen in all the sectors, we have no lack of creativity or innovation. And these sessions the last 2 days have shown that there are a lot of really great ideas that are at work. But these talents need channels that are supported by money and policies. And before we go to my suggestions, let me just point out that part of the discussions in our drug forum at the National Academy evolved when we went back to the proceedings of a meeting from, I believe it was 1985, and realized that as it related to pharmacology and basic understanding of what to do with aging people, everything that was said at that meeting pertains today. So while the science has advanced considerably, the practical application in terms of knowing what to do needs a lot of work. So let's go to the next slide. As I listened to people, I came up with 8 points and suggestions. And, this is obviously just my thinking, and reflects a lot of thinking I did about it while I was at FDA. The first is that the basic issues about pharmacology and aging really are unresolved, largely because we haven't effectively studied them. And I think in order to make this happen, in the context of drug development, industry needs an incentive or some kind of requirement, otherwise known as carrots and sticks, probably some combination of both, because it's not that it couldn't be done, but we study pharmacology in children because a law was passed that said you must study pharmacology in children if you intend to treat children. And we heard multiple recitations over the last 2 days about the underrepresentation of aging people in drug development research, and yet much of the sales is oriented towards people in this older category. Second point is that NIH has a relevant institute, and we'll hear from Dr. Bernard next. But I was very involved in the work at the NIH around setting standards for representation of underrepresented populations in NIH research. And everything I've seen is that strategy has worked. And Dr. Bernard already told us yesterday that there was a meeting on this that made recommendations. And I would just say, let's follow through with the recommendations. When you hold people accountable in their grants to do what the policies say, it's amazing how adept academicians are at reacting to the money, as I said before. Third point is that the complexity of comorbidity and polypharmacy really is daunting, and it's not getting easier. And while there is funding going to this issue, I think it really needs its own stream of research that needs to be bulked up quite a bit, because parsing this into its individual dimensions is clearly not going to solve the problem. I think many people have made that point over and over. It needs a holistic approach that involves the whole spectrum, from the basic pharmacology of drug interactions and the interaction of drugs with aging organs, to the phenomenology of what happens when someone's being transferred from an assisted living facility to a hospital and back and forth. Fourth point is that many of these critical issues can only be addressed by integrating research and clinical care. We heard that over and over, and we heard a lot of promising efforts that are underway. And I would just say that we need to really work through the specific approaches that can make this happen, because while the theory is getting better and better, my experience now in the Google Verily universe of working with many health systems in the United States is that the practice is actually evolving in the opposite direction. Let's go to the next slide, and I'll give some, at least a hint as to why I think this is the case. I don't think the issue in the first point here is that clinicians are not interested in advancing research, particularly in this area. But when you interact with the health systems that they work for, or the practices that they work for, there's little to no reimbursed time to participate in research. And so the point was made, if you got to take a half an hour to explain a consent form and you got 10 minutes per patient, you can't really fit that into the box and make it work. And there are so many strategies. I will say that in the previous administration, we got right to the verge, and there is an option in Medicare billing for a specific evidence generation tab that would give reimbursement for actually participating and involving patients in research as part of a clinic visit. That's just one of many strategies that could be used. Next point is that this is not a new issue for me, and I think it's very difficult. It came up over and over during the last 2 days. I particularly enjoyed the way it was discussed in the last session. But we really have a tension between the general ethical stance that evolved for good reasons, that people need to be protected from research, especially vulnerable people, but the knowledge, which has really become clear to the public in the COVID era, that if we don't do the research, we actually have no earthly idea what the heck we're doing. And so it just doesn't fit to only protect people from research. My personal view is that we need to embrace research as a fundamental normative ethical stance of clinical practice. But how to reduce that to practice and reach this right balance is something that I believe needs specific effort. And I would love to see funding go to empirical research that helps us figure out how to find this right balance in practice. I mean, my old friend Eric Topol made the point that the Apple Heart Study enrolled tens of thousands of people over age 65. But we really don't know at this point how that pertained to the many variations on the theme of aging were in play. And we really need to figure out for people, for example, with some cognitive decline, what the right approach is to make sure they're included so that we know what to do for them and the next people like them with protecting them from unscrupulous or misguided efforts at research. Then the next one is one that pertains to life in general right now, and is certainly a large part, I know, of the work that I'm doing, and I know that Dr. Abernathy is doing at the FDA. But, we now have a surplus of data, and much of it is in digital streams in one form or another. But it's not well integrated in a way that allows us to look at the holistic person. And the analogy I like to use for this is the blind man and the elephant, the old picture. Up until now, we've been limited in looking to one part of the elephant at the time because we couldn't compute the entire elephant. Now we can compute the whole thing and we can look at the environment in which the entire herd is operating. But we haven't figured out how to put all the data together, curate it, integrate it, and analyze it in a way that leads to meaningful conclusions. Much work in progress, but I believe it needs to be continued. And then finally, the special environments in which aging people often end up, assisted living, nursing homes, hospice. Millions of people are in these environments. They're fundamentally different, and I believe we need specific approaches to open up the research and quality efforts in those environments. So that's a summary of things that I took away from the meeting, blended with what I was thinking before, and I look forward to the discussion.